Good evening, everyone. I hereby welcome you all, and we take great pride and pleasure in bringing you the 11th series of the educational program, Advanced Classes in Dentistry. This program shall be conducted with our esteemed speaker, Dr. Hussain S. Basma. This educational program is brought to you by FDC Limited, makers of the Fleming Clip. Therefore, on the behalf of FDC Proxima, greetings to everyone. I now request Dr. Basma to enlighten us on the topic of guided bone regeneration.
Good morning, Aman. Good morning, everyone. Thank you so much for the introduction. Before I start, I would like to welcome all of you to being here today. It's such an honor to be sharing the stage on the 11th time, actually, to sharing a virtual stage for the 11th time with you guys. Today, or in the last couple lectures, I'm going to be focusing on guided bone regeneration. It's one of the hottest topics. It's one of the biggest controversials. Some of the variables that we're going to talk about that we are going to be discussing in details. What is the different types of applications? What is the different type of materials? And also, how to achieve predictability whenever we're regenerating bone in the maxilla or in the mandible. So before I start, for those who doesn't know me yet, I'm originally from Lebanon. I did my dental school in Damascus University, and then I moved to Lebanon where I did a specialty in prosthodontics. And currently I moved to Birmingham, where I did then I moved to Birmingham when I did my residency in periodontics. And I'm there as an assistant professor since 2018. And before I start, I would like always to give credit for the UAB team that allows me to represent them as I'm lecturing. So big shout out for the UAB group. And today I chose to talk about guided bone regeneration again, because of the importance of the topic. Anytime we're dealing with implants, this is a key factor for success for implant placement and for predictability of implant placement, because we all know that implants should be 360 degrees in bone, right? And whenever we're placing an implant, whenever there's any kind of resorption, any minimal amount of bone, we definitely need augmentation prior or during or after bone augmentation or after implant placement. But it's not only about understanding when do we do bone grafting. It's more about how can we achieve predictable outcome and how we can achieve stable bone during or for a long time. And the purpose here is to talk about some material selection that will give us predictability and avoid any resorption with time, avoid any implant complication with time. So if we look at all these pictures actually and all these cases, we can see that it's a complete, every time we deal with any patient, it's a complete different animal here. We're talking about mandible, we're talking about maxilla, we're talking about anterior, we're talking about the posterior, we're talking about intrabony, we're talking about extrabony, we're talking about horizontal, we're talking about vertical or combined. So we have a lot of different things that we should take into consideration whenever we are planning to do a bone augmentation, because the question is always, Dr. Basma, would you or Hussein, would you do this case with implant placement simultaneously, or would you do a staged approach where you do a bone graft first and then come back and place implants? So every single case is unique, and there are some features that we look at in order for us to decide if we are aiming to do only bone augmentation or we're going to do it simultaneously with implant placements. So when we talk about these factors, we have to understand what are those factors that we should look for in order for us to be able to place implants, in order for us to be able to achieve better aesthetic outcomes in the aesthetic area. And also most importantly is to have a long-term stability of our product that we gave the patient, right? Because it doesn't matter how much bone we grow if it's not going to last in the patient's mouth. So the whole purpose is to achieve predictable outcomes that allows us not only to achieve aesthetics, not only to achieve predictability, but also to make sure that we avoid any complications as following. This is a patient who presented to our practice that received a major bone augmentation prior to implant placement. Patient come back and the implants are exposed. Half of the implants are exposed. Why? Because that bone graft, the quality of the bone graft, the quality of the material that, or the different material that we used here, was not enough to hold that bone around the implants. In addition to other problems that could be related to prosthetics, that could be related to the type of the jaw we're dealing with, to the medical history that we're dealing with, but we have to understand the materials in order for us to be able to achieve a long-term stability of our bone graft. Just a little bit about the science behind bone augmentation. Usually, whenever we are talking about bone augmentation, we have to understand that there are some progenital cells, whether they are native from the body or from recruited that we use over the shelf, that has to be nested into the scaffold. And this scaffold allows for a space maintenance, and those cells will allow for have an osteogenic potential that's going to be able to target cells in order to transform them or differentiate them into bone forming cells. And then signaling molecules will come to facilitate this process. But what is most important is that we cannot be talking about regeneration. We cannot talk about regeneration if there is mobility. So we have to have a graft stability. And also we cannot, because we're working in the second dirtiest part of the body, which is the mouth, we have to make sure that there is a protection of the site by achieving primary closure. And after that, we are going to be able to have a predictable bone augmentation. So all these six golden rules that have to be present in order to have a predictable outcome. To summarize that, it's just the cells, the scaffold, and then the signaling molecules that it's going to try to target those cells to form bone forming cells or to differentiate into bone forming cells. And then with the help of the blood supply, with immobilizing the graft and having a primary stability or a primary closure, that's going to lead to a very successful outcome. But this is actually a small summary. Whenever we all know that whenever you have we're dealing with bone augmentation, we're dealing with two parts. We have the bone and we have the soft tissue, and that gap is usually filled with the bone. And we are trying to do what? Whenever we're dealing with those two factors, with those two products, which is the soft tissue and the bone, we all know that there is a consistent fight between those two, who is going to win. But unfortunately, the soft tissue cells are heals faster and they take the space, and we all know that the bone cells are very slow. So what we understand from this case is that we have to have something that allows or that prevent the invasion of the soft tissue in the bone augmented area, in order to allow the time in order for this bone graft to heal. And in order for us to achieve that, we have to have a kind of a barrier that prevents the soft tissue from invading that area. And that barrier is going to be discussed thoroughly in the next few slides. And after that, we put a bone graft, and we let that bone graft heal. And if we don't do that, what's going to happen? The soft tissue is going to invade that area, and leading to what? Leading to a failure in the bone augmentation. So it's very important whenever we're dealing with this, with any bone defect, unless whether it's there is it's a socket with a missing buccal bone, whether it's a guided bone regeneration case, whether it's a GTR cases, most of the times we are going to place a barrier membrane, preventing the soft tissue invasion. As I mentioned, we add the bone graft, we wait we ask for biology to happen, and then this is going to turn into what? This is going to turn into a patient's own bone, and then we are going to be able to place the implants. So this is the process as a summary. What is guided bone regeneration? It's literally using a bone graft material in addition to a membrane, and then preventing that soft tissue invasion from happening, leading to a successful outcome. But there are other factors that we should always consider. And as I mentioned, we have different types of bone graft. We have different types of membranes that we could use, and we have to understand the difference between those type of membranes and grafts, and where we're going to use them. because not every case is going to be different. Because if we're dealing with a socket, it's a completely different defect than when we're dealing with a guided bone or with a vertical rejuventation or a horizontal rejuventation. When we're dealing with an extra bony defect, it's completely different material than we're dealing with an extra bony intra-bony defect. So the whole purpose of this is to achieve an adequate quantity of bone that allows us to place an implant in a prosthetically driven 3D position, and then be able to achieve a good quality bone that is going to be stable and will have a better longevity and predictability with time. So definitely we are those two different cases. You can tell that the bone on the left and the bone on the right, one of them is very stable after bone augmentation. The second one, it's not the best bone, and you can see that it's a little bit mushy. So what we are aiming with is just understanding the selection of the material that in order for us to be able to achieve this product, because sometimes the bone is not mature. Sometimes we have to do a more augmentation at the time of implant placement whenever we feel that the bone is not mature yet. Why? Because whenever we place implants in a grafted area, there's going to be pressure on the area, and if the bone is not mature, what's going to happen? This is going to lead to bone loss around those implants. So in the market, we know that, we have actually different types of bone grafts. We have the autogenous, we have the allograft, the xenograft, and the alloplast. When we talk about autogenous, we're talking about bone from the same individual, literally taking bone during the surgery from the same patient and place it in the grafted area. When we talk about allograft, we're talking about a bone from the same species, but from a cadaver, basically. And that bone has been treated, and we have different options that we used before, but now we focus mainly on the freeze-dried bone allograft, and then we have the xenograft. The xenograft is from different species, and here we're talking about animal-derived bone graft, and then we have the alloplast, which is a synthetic origin. So we all know that we have different characteristics. We all know that we have different type of bone grafts. But what is the best bone graft that we should use whenever we're talking about this? So before we talk about this, we have to understand what are the different characteristics of bone graft that we could use. First, we have the osteogenic properties. Osteogenic property or osteogenesis is the type of bone that contain bone forming cells. That contain osteoblasts, and the only one between those four that is osteogenic is actually the autogenous. So basically, whenever what is this telling you is that whenever we have a defect that have a minimal amount of blood supply, maybe we should consider using autogenous bone because it has the bone forming cells, and that's going to help during the healing, and that's going to help with the growth factor and the signaling cells. When we talk about osteoinduction, we're talking about bone graft that has cells that is going to form that going to target some cells in order to differentiate into bone forming cells, such as the undifferentiated mesenchymal cells. And when we talk about osteoinduction, again, this is also helpful whenever we're doing bone augmentation, especially when it relates to those defects that are harder to regenerate. Autogenous definitely is an osteoinductive. Allograft also is an osteoinductive, but there is a variation in the amount of osteoinductivity between a freeze-dried bone allograft and a demineralized freeze-dried bone allograft. And we're going to talk about that in just a little bit. Osteoconductivity means that this bone can form a scaffold, and that scaffold will help the bone cells to grow and form bone during the healing time. And when we look at these characteristics, we're looking at the autogenous have all these characteristics, right? We're talking about allograft can be osteoinductive and osteoconductive. We're talking about xenograft and alloplast that are solely osteoconductive. They don't offer any regenerative potential. So what is this telling us? This telling me that autogenous bone has the best properties of the bone, and then allograft also. And the best part about allograft is that it turns over with time, and it becomes part of the same bone or the patient's own bone, and that's that's helpful. But the problem with the xenograft and the alloplast, those are or actually long lasting. If it's not resorbable, because it stays there, the particles stay there for a long time. So as a summary for this, if I want to use bone that helps with the regeneration, I would go first to autogenous. However, if autogenous is not available, I might consider allograft here, right? However, and also if I want stability, I might use just a little bit of xenograft. Alloplast is not the best material to be used, because whenever I'm placing my implant, I don't want the implant to be surrounded with a lot of dead particles, right? Why? What's the most important thing about bone augmentation or implant placement? Is that I want my implant to be placed in a lot of vital bone. Why? Because if anything happened after implant placement or after osseointegration, I want the implant or the bone to fight also for the implant. And if you have a lot of xenograft, and that's why we don't do sockets with xenograft mainly. Why? Because we don't want the implant to be surrounded with dead particles. That's going to limit the amount of vital bone. So, and that's going to be detrimental sometimes. As I mentioned, autogenous is the golden standard, actually. We can use it as a block graft. We can use it as a particles that can be scraped from anywhere, mostly from the ramus or chin, and it has all the best properties. However, we have some problems that could happen that prevent us from or limitations that could happen that prevent us from using autogenous. Sometimes we have to go and open another site. The patients might not like that, right? Sometimes we don't have enough resources, especially whenever you're doing like socket graft. You cannot harvest much from an area. Why? Because you don't need it in these cases, and we're going to talk about that in just a little bit. Long-term stability is a question still nowadays. Why? Because there has been a lot of documentation on the stability of autogenous when it's used as a sole material for bone augmentation. And this is a study by Urban when they were looking at the predictability of ridge augmentation with non-resorbable membranes and particulate autogenous. And they found that it's definitely a safe and predictable treatment. However, there should be a dimensional stability over time due to the high resorption rate of autogenous. And this opened our eyes to say, well, maybe we should use something else whenever we're dealing with defects that are more complicated, right? Like a vertical, like a severe horizontal defect. All these cases, we have to add or include more bone graft that helps with the stability, or different graft particles that helps with the stability. When we talk about allograft, it's definitely the best substitution for autogenous bone. We have different types of bone allograft. We have the demineralized, which is basically we remove the mineral, but the problem here is that we end up with a hard handling. Why? Because we remove the mineral in order to expose the BMPs in the bone grafts. However, demineralized freeze-dried bone allograft is not recommended in guided bone regeneration. We have the putty, the same. It's a mixture. Actually, it's very easy to handle. You can just place it there, just very close to the consistency of a sticky bone. When the bone graft is mixed with with PRF, we have the mineralized. And when we talk about the mineralized, we're talking about the cortical and the cancellous. And this is basically trying to achieve both or to combine both characteristics of those two options, which is basically whenever we use cortical, those particles stay there longer, and that helps with the space maintenance and the better density while placing the implants, and definitely mix that with a 50-50 proportion in order to achieve a better handling and turnover of the bone. So as I mentioned, allograft is one of the best options to replace autogenous. Why? For the reasons that I just mentioned. And then we have the xenograft. And xenograft should be solely used for stability of the graft mainly. And we always try to keep that bone graft away from not in contact with the implant. Why? Because we don't want dead particles that I mentioned around the implants. Yes, we have some studies that showed that you can use xenograft as the sole material for for guided bone regeneration. However, the long-term stability, if any problem happened to that implant, is going to be more detrimental. So when do I use xenograft? I use xenograft whenever I'm looking for a stability, whenever I'm looking for a case where I'm using autogenous, for example, because we mentioned that autogenous is not stable with time, maybe I should consider adding a little bit of xenograft in order for me to achieve an excellent quality of bone and at the same time a long-term stability of that bone. Okay, and then this is what I'm talking about. And again, here we have to understand, and you can see this is a vertical regimentation case, and you can appreciate the xenograft particles in that bone augmentation, and that augmented ridge. And the key is to understand that I'm trying to limit the amount of xenograft. So basically, around my implant. So basically, what I'm trying to do here, I'm trying to make sure that this bone graft is mainly vital bone, mixed with a little bit of those particles that are going to stay there for a long time. And this is telling you that my mixture between autogenous or allograft and xenograft, so basically if you're using either autogenous plus xenograft or allograft plus xenograft, the mixture or combination has to be no more than 70-30, meaning that the 70% of our mixture should be mainly either autogenous or allograft, and the 30% should be xenograft. No more than this. Don't go with 50-50 because the quality of the bone now here starts to have a lot of xenograft. Okay, and we don't want that to happen. When we talk about the particle size in guided bone regeneration, we are talking about using the small particles, which is from 0.5 to 1 millimeter particles, because it's definitely easier handling, better resorption, and better mechanical properties. And actually, we did a study at UAB, and it was recently published in the Journal of Periodontology, and we looked at the difference of bone augmentation outcomes when it's related to what type of, is it better to use a small versus large particles. And we found that actually that the vital bone formation was more extensive in the small particles compared to the large particle size. And this is helpful for the quality of bone that we're augmenting. However, the amount of residual graft and connective tissue were higher in the large particle group, which is very predictable outcome because the large particles takes longer to resorb. So all these are very important to know that, yes, we can use both small and large particles. However, from a clinician standpoint and from a clinician standpoint who used those two different types of bone graft, definitely highly recommended to use the small particles instead of the large particles. And when we're talking about the large particles, we're talking about the 1 to 2 millimeter pieces of bone. So as a summary for this, all these three materials can be used. Mainly, we have to whenever they are used, we have to understand that allograft is a better substitution for autogenous, and definitely it is going to turn over easily better than the xenograft and the alloplast. And whenever we're using, whenever we're aiming for a long-term stability, we are definitely aiming for what? For a xenograft and for an alloplast. Highly recommended to fit for xenograft, and that will give you easier or better predictability. And keep in mind, we don't want to do what? We don't want to mix or add a lot of xenograft or a lot of alloplast in our bone graft. Okay, we have to have the majority of that graft either autogenous or allograft. And this is solely related to what? This is solely related to defects that we're going to aim to grow horizontally and vertically. We're not talking about defects like sockets. Well, defects like sockets, we have more walls and we have more, and we're going to talk about that in just a little bit, because we have to understand blood supply. We have to understand the osteogenic potential of the defect that we're dealing with. If we understand that, we're going to know exactly what we're going to use in every single defect. Okay, so the aim whenever we're talking about vertical augmentation or a severe horizontal defect, we're looking at the type of the bone graft that will help us with the osteogenic, with the osteoinductivity, and with faster time healing. That's why we use autogenous. And then we're also looking at volume stability with time. That's why we add a little bit of particles, and those particles, no matter where they are located, they're going to be working on holding that bone graft. Okay, so it's a mixture of 70 by 30. And if autogenous is not missing, or is missing, is not available, we are definitely going to add or substitute that with allograft. And also, because we are not going to have exactly the same vital properties of that autogenous bone, we can add some biologics such as GEM21, such as BMPs, depending on the severity or the how severe is that defect. Okay. Then we covered the bone augmentation. Let's move a little bit into the bone graft material. Let's talk a little bit about the membrane selection, because we have in the market different types of membrane. We have the resorbable and we have the non-resorbable. And usually some of the clinicians mentioned that the non-resorbable membrane is the tie mesh, and the tie mesh is not a membrane. It has big pores, and soft tissue can crawl through those pores. And basically, it's called a tenting device. When do I use each one of these? So basically, a resorbable membrane is, from the name, it resorbs with time. I don't have to go in and remove that membrane. However, non-resorbable, there has to be a second surgery. There has to be another surgery to remove this membrane. However, the difference between those two is that one of them, which is the non-resorbable, can have the options to be titanium reinforced, and we use that in order to have a better stability of the graft. In order to have a better stability means that there are some cases that are very severe where we need more stability. We have to include the tie reinforced membranes or the titanium mesh in order to have a better selectivity especially for vertically augmented cases. When we talk about resorbable, we're talking about two different membranes. We're talking about the cross-linked membranes and the non-cross-linked membranes. Well, Hussein, what's the difference between those two? Well, non-cross-linked membrane is basically a collagen membrane that was removed from the source, and then basically we sterilize it and then we place it in the patient's mouth. However, the cross-linked membrane is that we remove it from the source, the collagen membrane, and then we sterilize it, and then we treat the surface with some chemicals such as like sugar coated or whatever, and then now we use it in the patient's mouth. The difference between those two is that the non-cross-linked membrane lasts way shorter than the cross-linked membrane, and the cross-linked membrane lasts longer. A non-cross-linked membrane can last up to, depending on the type of material or the membrane we're using, mostly between 4 to 6 weeks. However, the cross-linked membrane last way longer, and there are some membranes in the market that can last up to 6 months. So what is that telling me? That telling me that depending on the type of augmentation that I have and depending on how much osteogenic potential that defect have, I have to try to understand the selection of the membrane. So for example, if I have a severe horizontal defect, what do I use in this case? I need more time for the bone to heal. Then in this case, what I can use a cross-linked membrane. And there are some cases that I don't need much. So basically, if you ask me personally, what type of membrane do you use? Well, in this case, if I don't want to have a variety or selection of material or variety of membrane in my clinic, what we use is basically you can end up with using only the cross-linked membrane because it can work for all different bone defects, especially that when we're talking about bone, we're talking about a very slow healer. Okay, and when, again, as a summary, when do we use the non-resorbable barriers or non-resorbable or tenting devices? Is that when we're talking about a more severe defect. Okay, when we're talking about a horizontally severe defect, vertical augmentation, here we have to include those type of membrane. Yes, this tie reinforced membrane or the PTFE membrane can also come without titanium, and it can be used for extraction sockets where you place the bone graft, you cover that bone graft with this PTFE membrane, then you come back after 4 weeks, you remove this membrane, and then you let the bone graft heal for the time, which is around 3 to 4 months. So definitely those membranes are biocompatible. They don't create a lot of immune reaction. They are cell occlusive, as I mentioned earlier. They are going to prevent the invasion of the soft tissue into that bone graft area in order to allow time for that bone graft to heal. It has a better augmentation. Definitely space maintenance is one of the most important properties for that membrane, and easier to use. We have to understand that too. And when we talk about guided bone regeneration, there's or membranes, there's a lot of literature that supports the use of a collagen membrane, especially when it's related to different types of defects, whether you use a horizontal defect, whether you use a resorbable versus non-resorbable barrier, a cross-linked versus a non-cross-linked membrane. And again, the whole difference between those two is that one of them lasts longer. So and that could be the sole material that could be used where in guided bone regeneration, and that's not going to be any problem. Okay. So in order for us to decide on the bone augmentation, we have to understand some of the factors that can also help with or that impact the bone grafting, the bone graft selection, because there are some cases that health of the patient, depending on what's the medication and what's the patient's medical problems that could compromise the healing of the bone, could also impact our bone grafting. The final prosthetic plans, because there are some cases that we have to augment bone, and there are some cases that we have to remove bone in like all on X cases, especially when it's related to FP3 prosthesis, meaning that if you don't have enough space, and we already talked about that before, the size and the morphology of the defect is also a very important selection. And this is one of the most important things to understand, because it's not only related to the type of material, but also understanding the concepts why we end up doing bone augmentation. Because if we take this tooth out, which is, as you can appreciate on the distal of that molar, you can see the fistula there, and this tooth is deemed hopeless, so we took it out. But the question here, if you look at this socket right here, which is a very fresh socket immediately after we took the tooth out, this socket at some point was exactly equal to this socket right here. But look at the difference right now. A lot of bone resorption occurs. Why is that? Because we have a lot of studies that said that completely described or completely specify what's happening after we take the socket, because we all understand, especially in the aesthetic area, if we take a tooth out, where's the majority of the blood supply for that bone coming, or the buccal bone especially, coming from? It's mainly coming from where? It's coming from the periodontal ligament. It's mainly from the periodontal ligament, and also it comes from the periosteum, and that's the importance, which is a completely different topic. When we talk about implants in the aesthetic zone, that's the reason why we don't open a flap, because we don't want to be also depriving completely the socket from the buccal bone from blood supply. And again, we end up with different types of defect. We end up with a horizontal defect, we end up with a vertical defect, or we end up with a combined horizontal and vertical defect, and those are usually the most challenging. Okay, so when we talk about the classifications of defect, we're talking about this Kawood and Howell classification that talks about the different types, which is class 1, as you see right here, whenever you have dentate, or if immediately after extraction, when you have a horizontal defect, a vertical defect, and then we have the basal bone. But the most important thing out of all of this is to understand this slide right here. Okay, because we don't say nowadays that, oh, if you have a horizontal defect, then that's the material that you're going to use, or you have a vertical defect, that's the material that's going to use that we're going to use. Because nowadays what we are looking for is, we look at the defect as a whole. We have to understand 3 different parts of the defect. First of all, yes, we have to know if this is a horizontal or vertical, and if it's a horizontal, how severe is that horizontal defect? Do we have enough base for that bone? And also we have to understand the type of the defect, which is basically the orientation of the defect, part 1. Because if you have a sinus, it's a completely different sinus graft, it's completely different defect than if you have a horizontal or a vertical defect, because we all know that in the sinus we have more bony walls, and that will give you more osteogenic potential, and we're going to talk about that in just a little bit. And also, when we talk about any defect, we don't only look at if it's a horizontal or vertical defect. However, we look at how much augmentation is needed. How much augmentation is needed means, like, is it only like we can place an implant and we need only 2 millimeters on that buccal surface of the implant, or on the lingual surface of the implant? Or no, we need major augmentation, 5-6 millimeter when we have a knife edge ridge, and then we place our implants, because here also could a different factor will come into play, which is the material selection. And the third thing is, what is the most important out of all of these, is understanding the relation of the augmentation to the defect, augmented side to the defect. Why? Because it's completely different to speak about implants or defects that are intra-bony versus extra-bony. Meaning, when we say intra-bony, means it's a well-contained defect. It's at least, this is a defect, as you see in the upper right image, it's a defect that is surrounded with more bony walls. And when we talk about more bony walls, we're talking about more blood supply. Okay, and however, when we talk about extra bony defect, now these are more challenging. We have limited resources, and here the use of autogenous, the use of biologics could come into play to help with the time of the healing. Okay, and then we have to understand that it's only depending on the defect. There has to be a lot of understanding of the osteogenic abilities of that defects, because a socket is completely different than a one-wall defect, because a socket and a sinus, they are surrounded with bony walls. And when we're talking about bony walls, we're talking about bone cells that are coming from all the way onto that defect. And to give you a very quick understanding, if you take a tooth out, we all know if you take a tooth out and you don't do any grafting, there's going to be bone that is going to fill that socket. However, there's going to be some resorption that could occur. However, what is that telling me? That yes, it's a high osteogenic defect, that even we didn't do any bone grafting, the body was able to create a bone in that area. The sinus is the same, well contained, bony walls. We have, I don't want to say we have enough blood supply, but it's well contained. It's an easy defect to graft, right? That's why we say everything works in the sinus. Why? Because it has a good osteogenic abilities or good regenerative potential. When we're talking about three-wall defects, now we are missing one bone. However, this is it is also still high regenerative potential defect. Why? Because we have enough walls to support that area, and this comes here into play where we can say, well, Hussein, what we can do is we can place an implant immediately. We can do a bone augmentation, and we can still have a better outcome. Yes, that's right. We can do that. And also, we don't need a lot of crazy material to be used here, because the body itself will help with the regenerative potential. When we talk about two walls and one wall defects, now we're talking about more challenging cases. We're talking about very limited osteogenic potential, very limited mechanical properties, and very limited blood supply. And that's going to create or change our mind in what are the materials that we should use. Because in these cases, which is the 1 and 2 walls defect, we have to add more biologic. We have to think about more autogenous. When we look at 3 and 4 or 5 wall defects, we're talking about more. We're talking about maybe we can use allograft in this case and should be fine. So this is what it comes to understanding the quality of bone that we are using here. And when we talk about bone grafting, we're talking about different materials. And if you look at the literature, we have ridge split, we have guided bone regeneration, we have tie mesh, we have autogenous block, we have allograft block, and every one of these have shown successful outcomes in gaining horizontal and vertical vertical augmentation. Because if we look at the studies and we do a small literature review there, GBR has shown to have an amount of a horizontal bone gain around 5.5 millimeters. Ridge split, depending on this is not for every single case, it's at around 2.9, and block allograft autogenous graft is around 4.6 millimeter. So basically, there is not one. Actually, there's not one technique that can be said, well, this is a golden standard, right? Every one of them works. Everyone have predictable outcomes. However, you have to understand that most of them are technique sensitive. Ridge split, if you don't understand when do you do a ridge split, what's going to happen? You can literally lose all the bone. Tie mesh, if you don't understand that this is one of the highest possibility to have complications with the tie mesh exposure, and you understand the tissue manipulation, you'll end up with complication. Autogenous block graft, the same. If it get exposed, you're done. That's what you just already get a failure. So that's when we decide that none of these are a golden standard. Okay, all of them could be used, all of them could be, and all the literature support that. You can use autogenous, you can use you can use GBR, you can use distraction osteogenesis, depending on what's the case, actually, and every one of these should be respected and should be understood really well. And we have to understand that the fundamentals of guided bone regeneration are the following that can be based on the one study. It can be summarized in the PASS. PASS, P stands for primary wound closure, and we're going to talk about that in the next session, which is basically achieving primary closure in order to remove tension-free closure, also in order to have a well-contained defect and non-exposed defect to the oral cavity. Angiogenesis, where we have a better blood supply. Space maintenance, the type of membrane we're using. The bone augmentation also itself could be, or the bone graft itself could help with the space maintenance of properties. And stable clot, trying to fix the membrane and to have a fixed graft material in order to prevent any, because we already talked about that any mobility will be our enemy for regeneration. So I'm going to stop right here because the next session is going to go into the technique of GBR. What are the things that we look for? So as a summary for what we talked today, it's very important to understand the defect, because based on the defect, we understand the materials and the selection of the materials. Because if we have a one-wall defect, you saw that it's a completely different than if we use a two-wall, a four-wall defects, and a five-wall defects. Why? Because depending on how much osteogenic potential it is. Understanding those materials allow us to understand whether it's a autogenous versus allograft versus xenograft. When do we use each one of these? Those are very important, guys. We don't want to place a xenograft in a socket. There is no reason, unless you are using this socket just as a pontic. Why? Because I want this to stay there for a long time. I don't want resorption with time. So now you have to understand how can I play with those materials in order to have the best qualities of this, or the characteristics of this bone graft used. Because yes, you can use autogenous. Sometimes if it's limited, you can use allograft and mix it with more biologics. So with that, I just want to end the presentation here. If there's any questions about part one, which is the science behind guided bone regeneration, and next week we're going to be talking about the technique. Okay, so we're going to have cases. We're going to talk more about the each step of these, and how do we execute every one of those cases, whether it's a socket, whether it's a horizontal regimentation, whether it's a vertical regimentation. So stay tuned. Next week or next month presentation is going to be very exciting or very interesting. Okay, with that, I want to thank you, and I'm ready to open the stage for any questions. Please let me know, and it's an honor for me to be answering them. Thank you, guys.
So, well, with this, we have come to the end of this very educative and interactive session. And I'm sure audience would have gained a lot from today's discussion. A big vote of thanks to Dr. Basma for sparing his valuable time and being with us. I would also like to thank our educational partners, FDC Limited and CME partners, Spirent Communication, for conducting of the program. So happy weekend to all until we meet next time.
Thank you so much, guys.
Thank you so much, Dr. Basma.
Thank you, Dr. Gulshan.
Thanks. Have a nice day. Thank you.